Josh, you got a nice new haircut?
I did. Yeah. It's been probably 3 months since I got a haircut. So on the weekend, I ordered a set of clippers off of Amazon, and I was actually going to get my fiance to cut my hair for me. But when my clippers came in yesterday, I just got too excited to try them that I just went ahead and started. And once you do like the one pass, you have this huge
You
area
can't,
that's
you can't, yeah.
the rest, right? So
You have to do the rest. Otherwise, you'll have a patch in your hair, and that doesn't look good.
That's the word I was looking for.
Josh, I did something recently. I actually went back and rewatched all of the podcast episodes that we have.
Oh, there's a lot. You watched all 100 of them.
Yeah, I watched all 2 of them. But what I noticed, there's a huge challenge with ums and ahs and those filler words. It's such a challenge to get past those filler words. I don't know if you've had that same experience, but.
Well, it's funny. So, after we just said, after we filmed the first one, I noticed that I said like a lot. And
Yeah.
I don't know if that's how I always talk or if I just said that a lot during the show. Open to feedback on that.
No, I don't know. I all I know is that when it's on this video forum, that's kind of one of the main challenges is catching yourself saying and ah all the time. Another really big challenge that I was thinking about is readmissions.
So you were just thinking about ums and ahs and likes, and then your brain just went to readmissions.
What happened was I was thinking of the biggest challenge that is, facing us right now in this podcast. And then I was thinking, what's another challenge that's big in the world? And readmissions was just kind of top of mind. So,
well, speaking of readmissions, Alan.
That's great. Yeah. Honestly, though, speaking of readmissions, Josh, I know I talked with you when I first joined the company, and you had obviously learned about readmissions from your work in the healthcare industry. But I think that you probably have some stories that I don't know about readmissions.
Yeah, definitely. I mean, we touched a little bit on it in one of the past shows. I think for me, my interest really started actually in my, I think it was my second year of med school, I want to say. And as part of our training, one of the things that we have to do is an individual research project on social determinants of health. So just the basic idea that it's not just medical history that affects your health; it's social history. So it's things like folks coming from lower income environments are at higher risk of health issues, lower education, health literacy, and so forth. So all kinds of social factors that affect health. And I'm trying to remember exactly why, but it was really important to me to work on a project that I just personally found interesting. I didn't just want to do a project and just get it done. And at the time, I was thinking about maybe going into family medicine at some point. So, I wanted to position my CV a little bit to have something in family medicine. But I came across some work done by Toronto Western Hospital, and I ended up getting put in contact with a fantastic family physician. Her name is Dr. Sabrina Akhtar. And at the time, she was getting this house calls program off the ground for the hospital. And, I'm not sure how familiar, Alan, you are with like Dr. House calls at all. I don't know if you've even had one before.
No.
What's interesting is that, many, many years ago, house calls were more common and were accessible for most people. So back in the 1950s, let's say, in North America, probably about 40% of physicians did house calls still. And what changed over the last 50 years is that medicine became really centralized, both in the hospital and the clinic setting. And I think as of the 2000s, less than 1% of physicians did house calls at all in North America. It's maybe even less than that, far less than 1% now. But what I learned from Dr. Akhtar was that the patients who actually need healthcare or primary care the most often are the ones who have the hardest time getting healthcare access. Yeah. So you have all these, like, frankly, you and me, Alan, like these, younger, able-bodied, mentally able to take themselves to a clinic to get care. That's easy for people like you and me, but for folks who are homebound because they're particularly frail and elderly, because they have cognitive challenges or other just physical challenges, they can't come into the clinic to see their doctor. But because of all these other issues that are related, they have the highest risk of getting sick and ending up in the emergency department or being readmitted back to hospital because they can't get care when they need it. And so Dr. Akhtar, was trying to fill that gap where she launched a house calls program at Toronto Western, where herself and some other family physicians and residents would actually go to patients' homes and take care of them for the ones who really needed it, so that they wouldn't bounce back to hospital. And so, that got me both interested in readmissions in general, but really got me thinking about, okay, well, like, how do you bridge that gap for these patients who are stuck at home and can't get care? So there's always this ongoing challenge in healthcare about, like, well, how do you actually make healthcare accessible and easy and convenient for those who frankly need it more?
Right.
And anyway, so, work with Dr. Akhtar got me really interested in just, preventing readmissions or just keeping patients healthy at home in general. And then eventually that interest led me to my work at UHN, or Toronto General Hospital, where I did formal work on readmissions.
Right. So I know, what readmissions are. Makes sense. Patient is readmitted to the hospital or the clinic. Why would patients care about readmissions, or why should patients care? And maybe more broadly, why does the healthcare system care? Why do payers care? Why do providers care?
Yeah, well, so the thing about, and maybe it's okay with you, I'll back up on readmissions in case there's anyone listening who maybe isn't as familiar with what is a readmission and what it takes. So, imagine you end up in hospital because you're having surgery or because you're ill with a heart attack, and you stay for several days or even weeks sometimes. When we send the patient home after they recover, the truth is that you're not 100% back at your baseline. We discharge you as soon as you're reasonably safe to go home, you're stable. Because the truth is that bed capacity is almost always at 100%. We're trying to get patients home so we can let sicker patients in to take care of them. So when you go home, you're not 100%. And typically, you're probably not back at your normal healthy baseline for maybe a couple weeks, maybe a month. So that first, 4 weeks when you leave hospital, you're still at a risk of problems happening, maybe an infection or other issues related to why you were in hospital in the first place. And so, if the patient gets sick again, maybe they had a surgery and their incision gets infected and they don't catch it in time, they might end up back in hospital and readmitted. And, the hospital or the payer, the government cares about readmissions because they're costly. So the average readmission typically costs about $10,000 at least. And that's very expensive. And it's often preventable. So for example, let's say you did develop an infection at your incision that spread to the rest of your body, and that's why you're readmitted. Well, if you had caught the infection earlier, maybe you could have treated it with oral antibiotics and the patient would have gotten better. They wouldn't have ended back in hospital. So there's a major cost issue there for hospitals and payers. As providers, frontline staff, you just don't like patients getting sick, right? You go into healthcare because you're trying to help patients. And if you, as a provider, when you could have done something to prevent a patient getting sick, you wish that you did it. So from a quality point of view, we try to avoid readmissions. And then from a patient point of view, I think sometimes there's this myth that hospitals are a safe environment. The truth is that hospitals are not a safe environment. You have all these sick patients in there. There's higher risk of infections being passed in a hospital. I mean, right now, frankly, with COVID-19, many parts of the hospital, you're at risk of contracting it. So for many reasons, as a patient, you actually don't want to come back to hospital if you don't have to, because you're going to put yourself at risk of other issues.
Right. And so there's definitely a tricky balance there. I know physicians want to keep patients in the hospital longer if they can, because then they can keep their eyes on them and they can monitor the patient right in front of them. Whereas if they send them home, even though it's maybe in everybody's best interest to get them home, they don't have eyes on the patient. So they can't monitor, they don't know what's going on. And so there is definitely that percentage of patients that's going to come back to the hospital. They know that that's going to happen, but if they can't monitor the patient when they're at home, then they don't know if that's going to be the likely case for that patient. Do you have any thoughts on value-based care, or do you have an explanation for what that system even is?
No, Alan, I have no idea what value-based care
Never
is.
heard of it.
Oh no, it's all the rage now, and I think the U.S. in particular, when the Affordable Care Act or Obamacare came out, back about 10 years ago, part of that act was focused on transitioning the payment model to be more value or quality based, and I think one of the most prominent examples of that has been the readmission penalties that Medicare and CMS came out with. So, people might remember. Gosh, I can't remember what year exactly it was, but in the early 2010s, when they first started penalizing certain hospitals for readmissions for heart failure Medicare patients, and then I think also pneumonia and heart attack patients, and then they added COPD and so forth. And now we're seeing more recently with things like bundled payments, the costs around readmissions are an issue for total joints and cardiac surgery. And then I think even with payers, insurance, also getting into things like bundled payments with organizations, and obviously reducing readmissions helps drive down that cost. For the first time, organizations not just care from a quality point of view, but care from a financial point of view to stay in contact with patients when they leave hospital and find ways to prevent a readmission from happening. And so, readmissions as a problem aren't new, right? Readmissions have existed as long as you've ever had a hospital and you send a patient home from one. Readmissions technically always existed. It's just that it wasn't until the Affordable Care Act in the U.S. came up 10 years ago that providers and payers finally cared about actually preventing readmissions. Because as much as people in healthcare are well-intentioned, we are rational, human beings, and unless there's an incentive model that incentivize us to prevent something like a readmission or improve quality, it's sometimes hard to justify running the organization in a way to do that. But now we have those incentives, and so that's kind of why you're seeing people all of a sudden care in the last 10 years about readmissions, when in fact they've existed for decades.
Right. And so bundled payment is that incentive model. So bundled payment covers a certain period of time for the hospital expenses, or how does that work?
Yeah, so historically we're fee for service. The government or the payer would pay let's say the surgeons, the hospital, the rehab, SNF facility separately for all the care the patient gets when they're in hospital having surgery, recovering, and then when they go home for, let's say, the first 90 days after discharge. But with the bundled payment, the insurer, the government saying, hey, we're going to give you, let's say, 20 grand to cover all the costs for that patient in their hospital, and then whatever happens to them in the first 90 days. And if you spend more than that 20 grand, well, then you're paying that extra out of pocket. If you keep it below 20 grand, you can split the extra profit. You still have to meet certain quality targets. You can't just cut the cost and the patient gets sick, right? Yeah. But yeah, so for the first time, you have, let's say, a surgeon or a hospital saying, hey, you know what? I actually want to know how the patient is doing when they go home. Maybe I'll give them a call. Maybe I'll reach out to them, because if the patient doesn't do well, I might get dinged for it, right? So in the past, if the patient didn't do well and they came back to hospital and got sick, well, oh, great, that's more revenue, right? Not in the current world. Now in the current world, it's no, they come back. That actually works against your financial model.
Huh. And I suppose bundled payments also promotes better quality overall, and actually more than just quality, but it's breaking down some of those silos, because you do have to be in contact with everybody, and everybody has to be on the same page. Okay, we need to get this patient, healthy as we can within this period of time. And so if they're moving from, let's say, in hospital to then going to a skilled nursing facility, we have to be in communication with the skilled nursing facility to make sure that they're doing their job. And so it seems like it's maybe a good solution for breaking down some of these silos as well.
Yeah, absolutely. For example, for the first time, maybe providers want to actively avoid duplicating tests,
right?
Because that cuts into their margins now. Or maybe for the first time, you have let's say surgeons and anesthesiologists and other allied health saying, hey, let's come together and implement an enhanced recovery initiative, because we know that's going to help drop the cost and improve the quality. But we have to, in order to implement enhanced recovery, we have to all be friends and collaborate and talk and work together. But it's just funny, Alan, right? If you change the carrot, all of a sudden people's behaviors change. I mean, it just makes total sense, right?
Totally. Yeah. And on your point about enhanced recovery after surgery, a shameless promotion, but we've done a really great episode on enhanced recovery. At least I think it's a great episode on enhanced recovery after surgery, and talk about all those issues.
Alan, I would go as far as to say, of all the podcasts that we've done so far, that enhanced recovery show is a top 2 show of all time.
I agree. And I'm already, and maybe this is a bit presumptuous of me, but I'm thinking that this episode would probably make the top 3 just based on the content and the topic of readmissions. I think that's super important.
It just might. And you know what, Alan, I think you got to add Barack Obama now, because his Obamacare name dropped here. You got to make sure that he hears about it.
That's a great call. Yeah. You mentioned that physicians are now calling to patients because they want to know what's happening with our patients. They want to monitor patients. And so that's kind of the next wave of, as we've transitioned to this value-based care, we need a scalable way to engage and monitor our patients once they've left our facility or our care. How does technology in general, so not just SeamlessMD, but how does any technology help with this transition as we move forward to monitoring patients outside of our 4 walls?
Yeah, and I think it helps to start by looking at, before even technology, like what were ways that care teams were trying to address readmissions. So, the most basic thing that we've done as providers is, okay, when the patient's about to go home, we give paper and verbal education to them, right? We'll say, okay, let's say you've just had a heart surgery. Here's a list of the 7 things that you should watch out for when you go home. And if you get a fever, if your incision looks red, if you have difficulty breathing, okay, here's the number to call at our office, and then we'll try to triage that issue. But if something more concerning happens, if you have major sudden chest pain that's similar to like a heart attack type chest pain, or maybe if you develop sudden reticent swelling in your calf, which could be a sign of a blood clot, like you should come into the emergency department. So we create, we give patients a list of these symptoms and issues and what to do about them. But one of the challenges that we find with paper and verbal, as you know, Alan, is patients forget, they lose things. In fact, there's studies done that show between 40 and 80% of what a provider tells a patient, they just forget.
Right.
So there's that. Okay, so then what's next? Well, then many providers do what they call post-discharge phone calls. So usually 2 to 3 days after a patient goes home, if you're lucky, someone from the hospital, maybe one of the nurses, will give you a call, and he or she will go through a script asking you, hey, you're 3 days out of leaving hospital. How are you doing? Do you have any pain, any nausea, vomiting, signs of a blood clot? How was your incision, et cetera, et cetera. Okay, so now there's at least a touch point, right? But here's the problem. Usually you don't have a follow-up with your doctor until maybe a few weeks after you leave hospital. And so even if you're doing well, by the time they call you 2 to 3 days after discharge, well, what if something happens to you on day 7, day 10, day 15? And so if an incision develops later on and you don't catch it earlier, an infection develops later on, you don't catch it earlier, then maybe you end up back in hospital, right? For example. So the point is that, we have limited ways historically to engage a patient beyond some verbal, some paper, maybe a phone call. And so it shouldn't be shocking that when patients get ill, they frankly don't know any better. And then they end up back in hospital, unfortunately.
Right. And I imagine a lot of these cases could be avoided as well. If there was a way to track patients, they're outside daily or even like in real time, then you could either get the antibiotics to them faster so that you eliminate any infections, or
or if they have heart failure, early signs of potential readmission would be if their weights are trending up. For example, you could have caught that weight change earlier and maybe readjusted their heart failure medication, and preventing them from coming back. And here's the thing though, Alan. Maybe a nurse could call a patient every day to ask all those things, right? But that's not
it's not scalable.
Yeah, it's not scalable. Right. I mean, these nurses are taking care of so many sick patients already in the hospital, and to expect them to suddenly have time in their day to pick up the phone and call 100 patients every day for the next month, well, that's like more than just a day's worth of work, right? And not only if they call them, whatever the patient answers, you're going to document every answer, you're going to type it all up by hand. And then the data that they're typing up is probably not very useful from a, monitoring trends point of view, because it's all text. And then, well, what if you wanted to actually look at the incision? How are you going to do that over the phone?
Mm-hmm. Yeah,
right?
without them sending text messages. Yeah.
Yeah, and then you ask the patient to email you. Well, that's not HIPAA compliant, right? And so there's all kinds of reasons why you can't just do what we currently did, manually. It's just not scalable.
Right. And so there's this list of symptoms that, we're maybe calling a patient about and figuring out, but on 1 day or 2 days out of the 30-day period that they're at home before they're back to baseline, for instance. So I imagine the first step that SeamlessMD would have done was to digitize those symptoms or that list that we're tracking from patients. Is that where you started with the readmissions kind of reduction efforts?
Yeah, well, I'll tell you. So, plug in for episode 1 about the origins of Seamless. I'm going to touch a bit on that. But, when we started the company, we, initially were trying to solve readmissions for complex chronic diseases such as heart failure, because that's where my initial interest was. And at the time, none of the internal medicine mentors I had were interested in technology like this. And then they kind of suggested I check out surgery, which I did. And, one of the first things I did was I went to PubMed and I searched for surgery readmissions. And I remember I found 3 specific papers that were interesting. And I actually ended up emailing the principal investigators of all 3 of those studies, and actually 2 responded, and I spoke with 2 of them. But one of those groups was actually from Baylor College of Medicine in Houston, Texas. And they actually ended up being the first clinical partner we ever did anything with. And what caught my eye about the paper was the group at Baylor had basically done what they called a Delphi study on common symptoms after colorectal surgery, and in terms of what should be monitored for preventing a readmission. And I don't know, Alan, are you familiar with the term Delphi study?
No.
So Delphi study is basically an expert panel or an expert collaboration where you survey, let's say 10 different individuals related to colorectal surgery. And then based on their answers, there's it's called a Delphi method for basically narrowing down their responses to get to a set number of options that you want to go with. So for example, what they did was they found 10 experts in colorectal surgery and basically surveyed them on, okay, what are the most common symptoms after a colorectal surgery that could be an early sign of a complication or readmission? So there were things like fever, abdominal pain, nausea, vomiting, stoma output of a certain amount. And then the other question they had was, well, okay, if a patient has any of these symptoms, what should they do? Should they call in? Should they go straight to the emergency department? So basically, using this iterative Delphi process, they narrowed it down to a list of say 10 symptoms, and they had consensus on like, okay, if you had one of these issues, what should the patient do?
Right.
And I said, that's really interesting. And so I reached out and I said, hey, well, what if we, took those kind of common symptoms that you had in mind and the workflow you had in mind, which by the way, typically this is what would be in a paper handout that you get discharged, right?
Yeah.
Per patient. But what if we digitize that on a platform for patients? And so that way, if we recorded their symptoms, we could tell them, hey, you had, major chest pain today. You should go to the hospital for this.
Right.
And then actually see if that helps, prevent, readmissions or ER visits, or just helps the patient better understand what to do. So Baylor College of Medicine was actually our first partner. Where we today, that was kind of the foundation, which we today call our health check in the platform for symptom monitoring. But that was kind of the genesis for it. And the idea was that the patient could just check in every day, on their own and then get guidance. Now, it's definitely evolved since then. So back then when we had our first, ever implementation, there was no one monitoring the data in real time. Obviously now, as you know, a lot of our customer partners are actually monitoring this data. But conceptually, it's the same concept that we started with many years ago.
And obviously we've been doing this in multiple specialties, not just colorectal. Those health checks are those that Delphi kind of consolidated symptoms for patients. Do you know, is there a difference in specialty? Obviously there's no stoma, for instance, in like cardiac care, but
yeah, so I would say that there's certain common ones that are being tracked across most, let's say, these surgical specialties. So almost every surgical specialty is going to care about things such as, temperature, pain, although the location of the pain might vary,
right?
Incision, health,
right?
And maybe photos of the incision. So those are probably common ones. And then depending on the type of specialty, there might be some unique ones. So you mentioned colorectal, stoma output, and cardiac care might be, heart rate, for example, or certain types of chest pain. In knee surgery, it could be range of motion, how far you can flex or extend your knee. So we are finding that clinically there are some unique data points that vary, but certainly there is a common set that I think is universal for most surgical procedures.
Wow. And then SeamlessMD is obviously come a long way since that first use case that you first built out. What's the results been like with readmission reduction? Have we seen any good results in reducing readmissions?
Yeah, and I think what's interesting is that there's certainly a correlation between how much or how little of the data you use to address readmission. So, for example, we have some partners where they don't have staff available to monitor patients when they go home. But in those cases, because we're still giving patients automated feedback on the platform based on their symptoms and their progress, we've seen partners who have no real-time monitoring reduce readmissions by let's say 10%. But for those who actually have a provider who's getting alerts and monitoring patients and proactively reaching out to patients who are sick, at places like Baystate, they have seen readmission reductions of let's say 72%. And that's great work done by Dan Engelman and Joe Safi and team there. And then academically, we've done some great studies as well to better measure this. So over at Sinai Health System in Toronto, with the colorectal surgery program there with Dr. Aaron Kennedy and Dr. Alexandra Eason, they've done some great work where actually they initially started with a pre-post study using SeamlessMD for monitoring, and they saw a readmission reduction of about 66%. And actually they published that paper actually. We can link to that. And then after that, they did a single center randomized control trial at Sinai. And I don't think that's been published yet, but I believe the results were also similarly positive. But I think we'll wait for them to release that publicly.
Yeah.
And then they're actually about to launch a multi-center RCT of this initiative to further validate the impact the platform can have on readmission. So I think we have a lot of data now that shows that it works, but part of it now is just common sense to me. It's that, if you can monitor a patient and catch the issues that prevent a readmission, it's not shocking to me that the results have been so positive.
Right. Yeah, and I think it's really neat how you're doing both sides. So it's the monitoring and then also empowering the patient. So they still get that initial, if this, then this. So they get that initial feedback, to monitor themselves, but then also having the care team, they're able to monitor outside the hospital as well. That's pretty cool.
Yeah, this is kind of also how our patient experience has evolved and our learning has evolved. So, in that original work with Baylor, literally it was our V1 of our product way back when. All that the program did was it collected the symptoms and it spit out feedback to patients saying,
right,
you're fine, or call the nurse for this, or go to the hospital. But the patient got no other real education or context or engagement. Now our platform has been so evolved and sophisticated that we actually give feedback to patients on what's going on. So for example, if they have something minor, such as constipation, okay, well then we actually give them immediate feedback on what is constipation, how do you manage it, how do you avoid it in the future, or all the way up to, if they're having, if they have signs of dehydration or they have signs of a wound infection, we actually give them self-care education on that topic, on what it might mean, what they should do, but also, like why they should call in, for example. So we're giving so much more context to patients than we did before. And we're finding that patients really value that because, a patient doesn't have 10 years of clinical training to understand what these symptoms mean and how they should think about it. They need some of that in a very patient-centric way to be delivered back to them. So that way they actually do call when you want them to, or they manage at home when you want them to.
Right. That's cool. And then obviously with some of these readmissions, and you mentioned dehydration and other signs, maybe constipation, I imagine there's quite a few patients who traditionally would come back to the hospital because they know something is wrong. They just don't know if it's a serious problem or not. Maybe they've misunderstood the information, or they can't, follow the instructions properly. And I think that's more common than people think it is, where patients just don't understand what it is that they're supposed to do. And this is all a new experience for them. They're overwhelmed. Do you have any indication on what some of the common root causes would be? Is dehydration obviously a pretty big one that comes up? Or
I mean, the most common reason why patients would come back for something they could have taken care of at home are things such as constipation, because you're still getting some narcotics or opioids after surgery, for example. It does vary between different let's say surgery or healthcare conditions. I will say, a story that I remember is, with Dr. Carmine Simone and the work we did with his team at Michael Garron in thoracic surgery. One of the things that they presented about with the this was published as an abstract in the Chest Journal, actually. They found that through Seamless, they were reducing unnecessary ER visits. And the way they were doing that was there are some issues that happen after a thoracic or a lung surgery that a patient might think it is an emergency. Because, I mean, without context, I could see why.
Totally.
But when they get the actual context, they realize it's not. So, for example, patients can, they have thoracic surgery, they often go home with chest tubes to basically help drain fluid or blood from their lungs. And sometimes those get blocked. And those are typically non-emergency. And usually if a chest tube is blocked, you can actually just come into clinic and then the surgeon will help unblock them and then you're fine. But you can imagine as a patient, if it's blocked, you're just freaking out because you may, oh my gosh, it could be an emergency. I don't deal with this every day normally as a patient. And so what we did is we built into the program a workflow where, okay, we ask the patient, is it blocked? Any issues with it? And if it is, they get automated education that, hey, this is not an emergency. Call our clinic. We'll book you in tomorrow. We'll unblock it. Don't panic about this. And they weren't having that as an issue anymore in the emergency department.
Wow.
So basically, we figured out, okay, map out all the things that could cause an ER visit or readmission, and then kind of almost preempt the ones that are preventable by just catching it earlier and then just giving the right feedback to patients.
Right. And we've been, for as long as the company has been around, we've been interviewing our patients to figure out, what do you like about the platform, but what can be improved? And some of the comments that we have from patients are kind of on that point where they'll say, the platform actually told me about something that I didn't even know was going to be a question yet. I didn't even think to ask this question, and it gave me the right education. And now I knew to self-manage. I didn't have to worry ahead of time. So definitely less anxiety. That's a big common point of feedback that patients give all the time. And I can totally understand where that would come from now.
Yeah. And then you get providers saying they're getting less calls now about minor things because, to your point, we're preempting a lot of questions.
Right.
And yeah, it is better for the patient experience. I don't think patients like having to call in to get their questions answered. In fact, for some patients who they're embarrassed or they're scared to take up the doctor's time.
Yeah.
And so they don't ask their questions. And then maybe there are things that they should have asked for so they wouldn't end back in hospital, frankly.
Right. I know on one of the studies that SeamlessMD has with McGill University around using technology versus an in-person auditor for data collection and answering some questions, I think the study showed that SeamlessMD and the technology actually had 50% more information that a patient would give than to a person. So that kind of makes sense. If they're calling in, they maybe don't want to take up the doctor's time or the nurse's time explaining all this stuff, but on a platform where it's seemingly more like a wall that they're talking to, that they know that they're being monitored as well, they have more freedom to write whatever they need to write in there and tell all the problems that they're having.
Yeah, and the great thing about it too is that unlike a phone call, let's say the reverse of that, when a provider would in the past have called a patient to see how they're doing, there are lots of times where the patient's not picking up.
Right.
And so even on the nursing end, it's a better experience because they don't have to call a patient back, maybe leave a voicemail and play phone tag. It's like, no, like wait for the patient to check in, get a notification if you need it, manage the issue.
Right. So do you think that readmissions will ever drop to close to 0%?
Well, they will if hospitals don't exist anymore in the future and everyone somehow gets all their care at home and you have mobile units to do surgery and everything else you need, which by the way, we laugh about it, but it's not totally crazy at some point in the future that everything is as a service.
Yeah.
It's not going to happen anytime soon, but it would at the very least make for a great Black Mirror episode.
I was going to say,
world where everything is delivered to your home and you don't have to leave your home ever for anything.
Yeah.
But in the near term, no, I don't think so. I think, we'll definitely continue to reduce it more safely. And, as we advance things like maybe minimally invasive surgery or other ways of doing things to make it lower risk for patients, probably will.
Yeah.
Yeah. It's go ahead, Alan.
Well, I was just going to say, we've done a lot of work now in the readmission space and reducing that. I'll definitely link those case studies in the show notes so people can see, what actually went into that. I know there's definitely a difference. So you mentioned, some groups don't have the staff capacity to monitor patients and actually, take a look at the dashboards and, see what's going on with each patient after they've left the hospital, but they're still getting that self-management education. So they're still able to reduce readmissions. So there's definitely a balance there where, as long as there is some effort to reduce readmissions by empowering the patients using kind of those symptom trackings and then providing that education versus the full command center, taking a look at patients and having the staff resources available. Do you see that taking up a lot of time for the staff? So if they actually have to monitor the patients and they're looking at these dashboards, do they provide feedback ever? Do they tell us, it takes up, X amount of time per week versus what I used to do? Or do you have any data on that?
Yeah, I mean, I think the data we have is that most providers who are monitoring patients, I think I was reading, don't spend more than maybe half an hour a week, 45 minutes, something like that in total. And I think it comes down to what the priorities of the organization are.
Right.
So, if there's a priority to actually reduce readmissions and ER visits for some reason, maybe they're in a bundle or affected by penalties, I think they'll reallocate their time to focus on that. It comes down to if it's important or not from a quality or a financial perspective. And as it increasingly becomes the case, I think you'll find that 100 years from now, healthcare teams might look back at today and say, wow, we didn't monitor patients before.
Right.
That's so strange.
Yeah.
Why would we not want to know what's going on all the time?
Right.
Why wouldn't we care about the whole patient, continuum of care? Why would we only care about what happens to them in hospital? It's going to seem crazy that this was the way healthcare was 100 years from now, right? So,
and I think it's interesting as well. You talk to any physician, you mention, do you care about what happens to your patient outside of the hospital? Of course they do. Of course, everybody cares about their patients. But then when you really look at, well, what are you doing today? It's kind of like, oh, well, that is a big gap. It's a big, black hole is what I hear all the time. It's a black hole. We don't know what's going on with them unless they come back. Yeah. So definitely I can see how this technology would kind of fill in that gap. And it's definitely a necessary component for tomorrow's surgery. And that makes a lot of sense.
Definitely.
Okay. Do you have any other thoughts on readmissions that you wanted to share, or?
No, I am all out of readmission thoughts today.
I think we can summarize it: readmission bad, monitoring good. Makes a lot of sense. Well, thanks.
Good. Yeah.
Yeah, exactly. And surgery in the future will be all taking place at home and by all these mobile stations moving around. I think that's really awesome. All right. Well, I think we'll leave it there. I think we've hit some good points in there about readmissions. Dr. Joshua Liu, it's been a pleasure again. Thank you so much for joining on this episode. And folks at home, if you have heard anything on here that you want to dig in a little bit deeper, we'll include everything in the show notes, so you can take a look at the detailed breakdown there. If there's anything to do with readmissions that you think, hey, this might solve it as well, feel free to drop us comments and we can start the dialogue there.
Awesome. Thank you, Alan.
Thanks, Josh. See ya.
See ya.